Hey everyone, welcome to another session of Virtual Global Spine Conference. It's a pleasure to have Dr. Stephen Kalhorn here with us tonight. He's a full professor of neurosurgery at the Medical University of South Carolina. I've been following Dr. Kalhorn for quite some time. I think we actually have a lot of overlap in our practices, a lot of similar type interests. This is a very hot topic now, is thoracic discs, and I think we all see a lot in social media these days about endoscopic discectomies. Dr. Uribe talks a lot about the retropleural or transpleural technique to get to the thoracic disc, and Dr. Kalhorn is going to enlighten us today with his technique for his iteration of the MIS thoracic discectomy. So thanks a lot, Steve, for being here, and looking forward to your talk tonight.
Yeah, thank you so much for inviting me. I mean, it's really an honor. I didn't think someone of your reputation stature would be reaching out to me and finding me on LinkedIn and inviting me to do this. So it's really kind of cool to be part of this and to be among some amazing surgeons and to talk about this. So I never thought I would be doing this many thoracic disc herniations, to be honest. It seems like they're born in South Carolina and they grow here or something, but they just kept on showing up. And then there are not a lot of people that want to tackle these things because historically, and we'll go through this, the approach has been pretty morbid. But I sort of grown to really love them. And then the surgery is interesting and it's complex, obviously, and high risk stuff. And you really need a good team around you to be able to tackle these things. So thanks again for having me. So in terms of disclosures, I do receive royalty payments for intellectual property for devices I've licensed through our Zucker Institute here at MUSC in Charleston. But none of that's pertinent to the contents of this talk. The basics of thoracic disc herniations are they're obviously rare. They're a unique challenge and to spine surgeons. Most of them don't require surgical intervention. You'll see a lot of these folks in clinic and talk them off the ledge and tell them they don't need surgery. It's typically reserved for patients with signs and symptoms of a myelopathy or a medical or refractory thoracic radiculopathy, which is kind of gets missed for a long period of time because it's just such a rare distribution of pain, and people are told it's maybe shingles or something like that, or it's musculoskeletal. But the thoracic radiculopathy responds great to this surgery, obviously. And then, there's some really cool case reports in the literature about even very large thoracic disc herniations being managed completely non-operatively. So the small ones obviously don't need surgery, but there are these cases of a thing called calcific discitis, which has been managed non-operatively and published before. And so this is an interesting case of in the European Spine Journal from 2016 of a calcific discitis. And I've grown to appreciate this, and I really do think that the etiology of a lot of thoracic disc herniations starts with this process, which is inside the disc space. And if you look at, A, B, C, if you go through the alphabet here, this is kind of how it started on A, and then B is the axial CT, where it just looks like a massive calcified thoracic disc. The MRI is C, showing a giant, calcification there with cord compromise, and it grows and gets bigger, and then it regresses. So on D, E, and F, the thing completely goes away. And but it does start with those calcifications within the disc space, that kind of stellate pattern you see sometimes on CT scan, and then it kind of expands into the canal. And in this case report, it went away with just, non-steroidal therapy and restriction of some activities. And I've removed a few of these that have not gone away, and it looks like flow seal. You get in there, and I don't know if you've seen some similar things, but it looks like flow seal. It comes out granular, kind of sandy, and it just kind of goes up your sucker, and it's a little bit of a surprise, but that's calcific discitis. A little bit of a history lesson here. So Fandor Perot was a neurosurgeon, and he actually was in Montreal, and he came and he was the chair of neurosurgery here at MUSC a number of years ago. And he I didn't know this, but until I started researching this a number of years ago, but he had a particular interest in thoracic disc herniations, and when he came to MUSC, he would do them here too. And obviously the historical results for these types of pathologies are atrocious, right? So, this is like the picture you see in when you're studying for your written boards as a resident, like the laminectomy for thoracic disc protrusions is a big no-no, and everyone knows that. And, laminectomy alone doesn't make a whole lot of sense. And this is from the early data. Only 29 of 29 of all the protrusions that were looked at here were were cured, 22 were improved, and then 18, 16, and then 6 were either not improved, paraplegic, or dead from, surgery for for a thoracic disc, right? And that's obviously from, the back in the day in the 1960s and earlier on, where there just wasn't the similar medical care, and I'm sure if someone didn't have a rehab capability and that sort of thing too. But still, the results are horrendous for a laminectomy alone. So Perot is really a pioneer, and he wrote that no patient whose only complaint was radicular pain was made worse by surgery. However, the condition of most of the patients with severe neurologic deficit was not improved or was made worse by surgery. Of the 9 who were almost completely paraplegic, only 2 showed some improvement. In that particular series, there were central disc protrusions, 11 of those, and every patient had an increase in neurologic deficit postoperatively, and only 4 showed gradual improvement. So he kind of, raised the red flag and said, look, that we got to look at other approaches. And so he was a real innovator, and as well as many others around that time. But he, looking at the transthoracic removal of thoracic disc herniations, and this is his paper looking at the technique, uh, diagram of the bone to be removed for this. The people that have done this, and this is the way we used to do it too. In my training and residency, we would remove a chunk of the rib head, transthoracic, a big thoracotomy, expose the pedicle, expose the disc space, do a partial corpectomy at the level above and below, and then remove the disc. And this, you would eventually get to the point where you could bring a curette in towards the interface between the herniated thoracic disc and the spinal cord, and then push it down out of the way. And this is a pretty big operation. So this is actually one of Fanner Pro's videos that they made that we've had in our archive here that we looked at recently. And so you can, for folks who have not done this before or not familiar with this is the way we used to do it. And that was the incision. This was the way that it was opened. That was the hand going in to push everything out of the way. I mean, this is, people still do thoracotomy for spine operations, and for thoracic disc. In some cases, it's not obviously this big of an exposure, but this is what was the treatment for thoracic disc back in Perot's time. Rib harvest was just complete rib resection, no replating back, right? Those ribs are usually just gone afterwards. Chest spreader, long, no retropleural access, just double lumen tube with anesthesia. That's taking down right there. That's the rib head down at the base of the spine, going into the zygapophyseal joint. That's the intercostal nerve and neurovascular bundle that's preserved. Identifying thing with a spinal needle and X-ray, heart and lung visible. So, and then drilling this all away, and you have all the room in the world to work here, and great visualization, and carefully using a drill to remove that portion of the bone I mentioned, basically doing that partial corpectomy of the level above and below, preserving the intercostal nerve, of course. So after you get down kind of towards the opposite pedicle, right? Because you've drilled away with the ipsilateral pedicle, you're going to the opposite side. You'll eventually expose the thecal sac, and then that's the disc with that curette pushing that disc down away from the ventral dura, getting the disc fragments out piecemeal, and eventually you get in a nice thorough decompression of the thoracic cord.
Stephen, how in the world did they capture such incredible video this many years ago?
I don't know. This was in our archive, and when I saw this, I couldn't believe it. It was just a real gem. I mean, that's the shark bite that people used to use to take these things out. So anyway, that's a typical open incision, obviously, and the larger increased opiate requirements. There was obviously double lumen tube, chest tube postoperatively with a lot of pain, delay in mobilization. I remember in residency, I mean, these folks would just be miserable in the ICU. They're just so sore, they'd get pneumonia and, just linger for a while. You'd of course need an access surgeon to get you down there. So more modern times, obviously smaller incision. We're talking minimally invasive. We're more outcome driven, right? To do that to someone in the hospital now would be like, it doesn't make a whole lot of sense. The length of stay alone, you get dinged for it. People are on social media. Patient satisfaction is obviously really important. It always was, but I mean, now we're just more and more aware of these things. And of course, we have hardware and less invasive ways to do things. So if you look at the spine, there obviously, people are familiar with the ways to get there. And I just talked to our residents about, kind of you can go around the clock about, how to approach these things. There's obviously a laminectomy alone, laminectomy with a discectomy, transpedicular, costovertebral, and you just go more and more lateral. So that's an extracavitary approach. And then there's the mini transthoracic and open, retropleural approaches, which are really slick and great. And then direct anterior approaches, which have been described, but really, I think that's just like bygone times, and no one's really doing that much anymore for thoracic discs. And then, so if you go back and forth between these two slides, the posterior stuff is really great for ligamentous compression. The soft lateral disc, perhaps for, if it's a laminectomy alone with maybe a little bit of the pedicle, you can get a soft lateral disc. Soft central disc, even coming from a little bit more lateral to get that central component. And then these large calcified central discs, the giant kind of the arch nemesis here, that those are best approached historically from more of a extracavitary kind of approach, and as well as from a transthoracic. When we talk about the giants, that usually means, in the literature, people are talking about a disc that's occupying more than 40% of the spinal canal. And then that's really a unique subclass of these thoracic discs. And like I mentioned, those are traditionally approached from the approaches we've discussed, transthoracic. So we've gone a number of years ago, I stopped, I didn't really ever do the open access surgeon thing when I went into practice, and I went to just approaching these things through the retropleural approach. And I guess initially, I don't know why I did that initially. I guess I couldn't get an access surgeon. I said, it can't be that bad. I was doing laterals and kind of read about it. And I said, let's just do the retropleural thing for these things and we'll be fine. It can't be that bad. And so, the invasive guys had provided some of these slides, and I think probably Juan Uribe, who's the thoracic disc god, really, at some point loaned me a few of these slides. I think he must have, but this is what needs to be exposed for that surgery. So it's less invasive. The incision you can see is much smaller. This is the direct lateral retropleural approach. It's less pain, earlier mobilization, fast recovery, and again, you don't really need the access surgeon to get there. How do we get there? Well, I always put these pedicle markers in, because that way you just don't have to guess about the level. This has been well published to reduce, chances of wrong level surgery, et cetera. But it's a little either aneurysm coil that you have our vascular guys put in, our neurovascular guys put in their radiology, and that kind of gets you to the level. It really helps you avoid wrong level surgery. It avoids a lot of emails and meetings like this, right, where there's 6 lumbar vertebrae and 12 thoracic vertebrae. And so it really simplifies things and takes a really high-risk, stressful surgery, and it simplifies it and removes that part of the stress out of the operation. With modern instrumentation and hardware, you are your own access surgeon. So you have rib dissection tools and everything you need to get down there, disc prep and even corpectomy stuff that we do. Lung retractor blades to shove stuff out of the way. These Doyens and Alexanders, you saw in the video, those are still really key to strip the periosteum off the rib head and to get the neurovascular bundle out from underneath their rib. It comes with, rib cutters and great Harrisons, corpectomy, Lexels, which are double action that can help remove vertebral body for doing a corpectomy for tumor or whatever. It's lateral, just like lumbar, but you don't have to flex the bed at all. You're obviously not worried about the iliac crest. You need really good AP and lateral images to make sure you're going directly into the right spot. Make sure the end plates are all perfectly lined up. So when you come down onto that vertebral body, you're not skiving in more too anterior. You're not going to like dock on top of the aorta or something silly. The localization is like you would do with the lumbar lateral, but basically I mark out the anterior part of the vertebral body, posterior part of the vertebral body, and then the disc space that you're going to. And then I make the incision along the course of the rib. The incisions may be like, 4 centimeters, 5 centimeters, not that big, but you just got to keep in mind that the neurovascular bundle is on the underside of the rib. So you dissect above on the superior edge of the rib, like you're putting a chest tube in, and that's all pretty safe up there. The bundle's underneath, and so you're not going to nick that thing going in. Use your Doyens and Alexanders to free up that rib. I've taken the rib, I've used it as autograft, I've used it as structural autograft. You can also plate it back. I've also just not plated it back. But I think if you do something with the rib and plate it back, I've had people say there's a little bit less pain if you plate it back. There are rib plating systems you can use that are commercially available. I'm a neurosurgeon, so I've just used that cranial plating system and plated it back too in the past, and that's worked pretty well. Once you take the rib, you got to really take it as far back as you can posteriorly, because when you run your finger down, you stay in this retropleural space. The further back you can go, the less of this overhang of the rib's going to be on your finger here. So the further back you go, and then you can just sweep and you feel the pleuro just dissect off the underside of the thoracic cavity, and then you get down, you can dock on top of the vertebral body. You got to be careful at the thoracolumbar junction because the diaphragm comes into play. And so if you're at, say, like T12 or L1 or even like T11 or so, the diaphragm can be a problem, and I really haven't had a whole lot of issue with that. You just have to really understand that you can't make a huge hole in the diaphragm. That the concern is you'll get a diaphragmatic hernia, which can be a problem later on and difficult to repair. I've not encountered that, but I think it's because when you do this with a MIS retractor, you're making a very small hole in it. It's not usually an issue. All right, so then you got you're coming down basically retropleural, and you eventually get to this point where you dock your first dilator on top of the vertebral body. The lung is basically pushed out of the way, but you're all retropleural, so there's not a concern for pneumothorax. There's no need for a double lumen chest tube. So we used to dock down. This is how we used to do it. We dock down, and then you would take your AP lateral fluoro, you would visualize the disc space, and then you would do the same operation that Dr. Pro used to do, but just through a tube. So removing the vertebral body, coagulating the segmentals that come across the vertebral body. The aorta, believe it or not, even if it's like sitting directly on the lateral aspect of that vertebral body on the MRI scan, will move out of your way most of the time with dissecting downwards. And so that's really not that big of a concern. But the annoying part is just hitting a segmental or something like that. But that with, Aquamanus nowadays and, these other quick clot things that are available, it's really not that big of a concern. You do your annulotomy, your discectomy, and then you kind of do your thoracic discectomy like we've shown. So a couple case examples, and this will kind of lead us into how we started doing this a little bit differently, because we had a case many years ago now that it was just not safe to take it out to transthoracic, and you run up to something like that and you wonder if there's got to be a better way, and frustration is kind of the mother of innovation, I guess. So this is a case of a 46-year-old lady who is neurologically intact and had a radiculopathy and thoracic radiculopathy with severe cord compression. She had signal change in her spinal cord on the MRI scan, and she was reporting some gait imbalance and stuff. So we thought this was obviously big enough to be causing her problems. We offered her surgery, and so we did it that way. So this is the bone that we removed as we described. I'll show you the operative pictures from our standpoint. So the retractor is much smaller. Again, that's removing the partial corpectomy level above and below. That's pleura and aorta anteriorly there, and the posterior is labeled up top. You basically drill that away until you see the disc herniation, which is, I don't know if you guys can see this mark here, but it's this thing here with the fecal sac running this way. Oh, that's never going to go away. Let's see. Let's see if I can do that. Okay. And then eventually you pull the thoracic disc herniation off. That's the fecal sac at the top, and then you're done. So this is someone who has a very large thoracic disc herniation. Her blood pressures, if you let them drop down even during surgery, you'd lose signals in the right leg. So we kept her in the ICU post-operatively, kept her on pressors for a couple of days. Because we were retropleural, there was no chest tube, no pneumothorax. She went home day 3 and then had some transient weakness in the right IP. Otherwise, she was full strength at her 30-day follow-up. So just a couple tips for going, if you're going to go approach these things from the kind of retropleural approach, is just beware of the aorta on its course. It will mobilize, like I mentioned. You really can't get to high thoracic disc levels, which is another problem with this approach. You're not going to go up at like T1, T2, T3, T4, all these levels, because of the aortic arch and the mediastinum. And so that is a limitation of the approach. The wrong level surgery is a real big risk, but I think that can be mitigated with placing a marker preoperatively. Neuromonitoring is obviously, I think, pretty critical, and it's not preventative, but I think it does give you some early warning signals in some cases. And then like Sonopet, and then this is like an ultrasonic aspirator, is really helpful in a lot of these cases where you can paint away the calcifications and then you can float whatever remainder is there. And floating that calcification is something I used to do. I don't really do that anymore. I think it's more of like a bailout strategy. I usually just try to remove it now completely, which again I'll get into why and how we do that with our different approach. If you put a red rubber in the pleural in that retropleural space and just have anesthesia valsalva, you don't get a pneumothorax on postoperative chest X-ray most of the time, even if there's a small pleural violation. So those are some of the kind of tips and complication avoidance for the transthoracic retropleural that we used to do. So some other issues. So we talked about diaphragmatic hernia. CSF leaks are a nightmare. I mean, in the chest, especially if you have a pleural violation because of the negative intrathoracic pressures, it's just a nightmare. So if I think I'm going to get a leak, I'm not going to just be a hero and try to pull it out because it's just a really big problem to manage, and it can be. I've seen some nightmare situations from that. This
Stevie,
picture,
can I ask you a quick question?
yeah.
About the last case you showed. It's a
Uh,
fantastic case. I'm just curious what your thoughts are about the necessity to fuse these patients. I personally go back and forth about it. Do you think that, when you do this lateral retropleural approach, that you're taking enough biomechanically relevant structures, maybe mid-thoracic spine, that you could potentially destabilize them? And what's kind of your indication for fusing here? I'm curious if you've gone back and forth like I have.
yeah, I have, and so I'm glad you asked because I stopped fusing them. Um, because I don't know why I did. And when looking back, I'm not sure why I fused them because you're not destabilizing them at all. You still have all the posterior elements that are intact. You're removing only a very small portion of the disc and the vertebral body. And so I stopped fusing them. You're not destabilizing them. Um, and so, yeah, this is an old case. And so if I did this again nowadays, I wouldn't do any hardware at all. And I think that's similar to what other people are doing in the country that is, and I think some of these people unfortunately show up with a lot of pain, right? They have pain, like axial thoracic pain or whatever it is, musculoskeletal pain. It's not radicular. And so I've also thought, okay, maybe a fusion will help reduce that if you take the disc out. Maybe that segment's abnormal somehow, and that's why they herniated their disc. But I have not been able to successfully get rid of that symptom in that patient population. So I think their pain still persists, that kind of pain, the non-radicular pain, with or without fusion. So I don't think it's beneficial or necessary. Um, Okay, so another little trick here. This is an 80-year-old who's referred through a pretty big thoracic disc herniation, symptomatic, and then this is something I just teach our residents. Look at the whole scan because this lady had an aortic dissection or aneurysm, and just because of that, we went on the right side, and that was just a little bit of a nuanced case. And the right side's wide open. It just if you get into a venous bleeding, it's harder to stop, obviously, than some arterial thing. All right, so this is the lady with a thoracic radiculopathy. This is a great approach really for obviously that problem because it's a lot easier. The accident it's just not as high risk, and people usually do great from that kind of thing. But it's post update 2 discharge and pain resolve with delayed follow up too. So this is where we started getting into some thinking about something different because this is the case where it just wouldn't come out. It was like it was just impossible. I spent a long time. This is one of the bigger ones we've encountered, and it's just a giant thoracic disc. Again, it looks like that calcific discitis in the disc space that spread into the canal, and it wouldn't come out. So that's like the swing and the miss. We spent forever trying to pull it out. I felt if I pulled it out, I was either going to paralyze the patient or get a spinal fluid leak or both. And so it was like our kryptonite. So I went home. I was like, why? How can we get this thing out? What are we going to do? And so I was thinking all these approaches that we talked about are all, extradural approaches. They're all, you're moving things out of the way and what if I just went in the back? I was like, that is so much of an easier operation if I just went in the back and then just went transdural and took it out almost like a calcified thoracic meningioma, like an intradural tumor. And so I looked, and sure enough, like I remember just laying in bed and looking this paper up and seeing that someone had, of course, described this already, and posterior transdural discectomy. So that was a new approach for the removal of a central thoracic disc herniation. So they described a paramedian dural opening, unilateral approach, and then rotate, tacking the dura up with suture here on the top of the screen, and then pulling the thoracic disc out from a transdural approach. So the cord is completely protected, and you're not you have good visualization. And in my case, we had already made a huge corridor up front from the partial corpectomy at the level above and below. So we had an area where we could just even tamp down the disc herniation if we needed to from the back. So that's what we end up doing in this case. And when I was doing this case, I thought, why would we ever go through the chest again if if it can just be done this way from the back? And so this is really, that was the case that really changed everything in my mind. And everyone's different. It's not like the only way to do things, but at least in my hands, in my mind, this is like eye-opening, because now we have a way to remove these things from the back and for any level really in the thoracic spine. So this is our case, and that's the residual disc, calcified nugget with dura tacked upwards there. You can see the dentate ligament just above the disc herniation there, and the spinal cord just above that pituitary. This is that Sonopet for those that don't use it. It's just an ultrasonic aspirator that can just, it doesn't vibrate. It just kind of cores away bone, and it's really safe. It's not like putting a drill down here that's going to spin this thoracic disc herniation around and clobber the spinal cord. So we debulked it with that, like you would with a calcified meningioma, for instance, and then we're able to push it down and then remove it, and the cord goes back into normal position. I mentioned in the last slide we did wait a couple weeks because I didn't want to get a CSF leak to communicate into the chest cavity, so we waited a couple weeks for that to kind of scar down. We didn't take that patient back right away. We let the pleura scar down, so we didn't have that problem. So this is kind of fun. This is I'm glad I had that paper to at least read and go off of, because I don't think I would have had the guts to do this if someone else had not published this, because it just showed that it was a reasonable thing to do. And I mean, there weren't really many other good options.
It actually makes a lot of sense, Stephen. I've actually taken this approach for some of these very large retroodontoid cysts. So
Yeah.
typically, we don't need to resect the pannus, but I've had several cases where these patients will present with a very large cyst dorsal to a pannus, and they're almost immobile. Essentially, they're tethered to the dura. Like you cannot separate the two. So what I've done is exactly what you showed here: open up the dura, rotate the spinal cord, on the dentate ligament, and you can actually take the cyst out and you go ventral transdural. Right. The question I
Yep.
have for you in this location is, what are you doing to reconstruct the anterior dura, or are you even doing anything? Are you putting like some type of alloderm sling there, or are you basically just tacking it down with something? Like how do you address that issue potentially of like a ventral CSF leak, or to prevent
Hmm.
ventral cord herniation potentially?
So I've done it two ways. One is I don't put anything there at all, and that's worked totally fine. In our series, we've had zero CSF leaks, thankfully. And the other way I've done it, I've done what you described. I've had both kind of pedicles drilled out, and I've put Duragen or Durapair, one of these like suturable dural matrix, all the way around, like wrapped it around extradurally, and then tied it at the top, and made sure it was not too snug, obviously, and then kind of glued over that. They both honestly worked. I thought the sling thing was unnecessary after I'd done it, because the other patients didn't leak either, and I'm not sure what that actually prevented, or maybe it stopped, like you mentioned, eventual cord herniation. But in general, I don't put anything in the front, and it heals fine.
Yeah, I'm fascinated by that in these cases, that these patients actually don't leak afterward. Every
Yeah.
once in a while, we see these patients that present with intracranial hypotension and they have some, minute CSF leak somewhere along the
Yeah.
neural axis, right? And we can't fix that, but yet we put these big holes in their anterior dura and they don't leak and they don't herniate their spinal cord. So I don't understand the pathomechanics of it. I don't know if you do. But
No.
I agree with you. The times that I've not been able to get a watertight closure, which is like 100% of the time, they never leak. So
Yep.
fascinated by it.
Yeah, it's really, really wild what we don't understand. Um, This is the post-op scan. So after the swing and the miss and the residual thing, it's gone. This is the MRI showing the corridor, and this is so because we had drilled out in the front. This is just a contained pseudomingucil that would look. It's kind of an interesting picture. The spinal cord. This is a good example. I mean, how that thing doesn't like wander over there a little bit. I mean, it's kind of wild, but everything's fine and there are no symptoms. So. All right, so then we just added, the transdural discectomy to our armamentarium, and then we wrote that up, and that was published in, um, along with that video. So just talking about that as a bailout option for really challenging cases where, and I still will use this occasionally if I just think the thoracic disc has already violated the ventral dura. I'm just gonna like, okay, great, fine. I'll just go through and look at it when we're in an easier corridor, and take it out that way, and because it's already violated the dura, you might as well go through and take it out that way if that's the situation.
The thing I like about that approach is that you've got complete control over the spinal cord, right?
Yep.
When you're extradural doing these calcified thoracic discs, whether it's retropleural or transpedicular, you don't really know where the spinal cord. I mean, you know where it is, but you don't, right? You're not actually, you don't have eyes on it. But when you're have the dura open, you can protect it, right? You can find the dentate, you can rotate the cord if you have to. So I feel like you really have ultimate control of a case by going posterior transdural as you've shown here.
Yeah. Yeah, I totally agree. It's almost just, yeah, I totally agree. I have seen, and I'll show a case where there are troubles that can pop up doing it that way, and so I try to avoid it if I can. But you're totally right. You can see everything. There's just less worry somehow. You've gone transdural and it seems crazy, but it's actually less worry.
It's not crazy. It's actually a very simplistic approach that works. We tend to complicate things as neurosurgeons sometimes, but it's a very simple approach that makes a ton of sense, actually.
Hmm. So yeah, after that case, I said, okay, well, it's 2025. This is years ago, but it's not 1969 in Fanner Pro. It's since passed. Like, why don't we just all do this all posterior? It's better visualization. It's a more common procedure. We all can do a laminectomy. It's the same tools we're used to using every day, et cetera. So on top of that, ultrasound has really improved a lot. These ultrasonic aspirators are really helpful. And then, obviously neuromonitoring are great partners in doing these types of surgeries together. So we've kind of coined this term ultrasonic spine surgery for doing this because we use the ultrasound to guide us to look where we're going, and then the sonopet thing to core it out. And they're different tips, but like the micro claw seems to be the one that works better because it points at a 90-degree angle, and you can directly attack the thoracic disc without worrying about getting a spinal fluid leak. So this is really the ultrasound stuff. The ultrasound stuff is just such a game changer. So this is a thoracic disc before removing it, and you can see the spinal cord there in the middle. You can see the dentate ligaments, actually nerve roots, and then you see the big ventral thoracic disc push on the cord and deflecting it. This is the sagittal. And we have a dental tool in there or something like inside the thoracic disc, moving it around a little bit, but you can see that mushroom of a disc pushing on the thoracic cord. And this just gives you all the confidence in the world. Obviously, one, it tells you that you're at the right level. Two, um, you can see what it looks like before you start tackling it, and then it just tells you when you're done. So you can keep on taking out more and more disc, and then you just keep on going until it's completely gone. And you can get a lot of information from this. You can see, God forbid, if there's cord signal change developing in the cord, which I've seen, a couple of times I can remember. Um, and then it just gives you the confidence that that you're done. And so this has really changed a lot of what we do, and it's just awesome.
So
This is another
what
example.
pushed you towards going transdural versus, an extradural, maybe kind of like a mini open unilateral transpedicular approach?
That's that.
What radiographically is it exactly that makes you do one or the other?
We'll almost always do just a unilateral or bilateral transpedicular, and then only rarely have we had to go transdural. And so I'll go through our series, and I think there were only 4 that we actually end up doing transdural on. So I try to stay extradural, and I'll show you or one of these cases why I try to avoid it, but if you can. But usually it's transpedicular. That last case was an example. That's all transpedicular too. Um, this is a case we actually did yesterday. So this is pre and post removal. The top is pre, bottom is post, and This is with a newer ultrasound machine that it's just the technology has gotten so much better. You can just see everything really so much better now, and it's really easy to use. So this is the same case from yesterday. So this is the posterior approach. This is why we went this way. This is 3 centimeter, 4 centimeter incision, standard laminectomy. And then what we remove is the really like 2 or 3 millimeters of the pedicle. It's not the whole pedicle. There's no fusion necessary. There's no need to do more than that. The visualization does not get a whole lot better if you go more lateral. It's still, like you mentioned, somewhat blind in some of these maneuvers. And
This video shows the
this is
ultrasound-guided approach
approach.
for the partial transpedicular thoracic discectomy using ultrasonic aspiration for safe removal of even large and midline calcified thoracic disc herniations from a purely posterior approach. These are the patient's films showing a large ventral disc herniation as well as calcification of the ligamentum flavum. The patient was myelopathic on exam. We start by removing the spontaneous process with hand tools, followed by using a high-speed drill to complete a laminectomy down to the dorsal compressive ligamentous structure and ossified ligamentum flavum. The bone is thinned out to an eggshell thickness. The ligamentum and the remaining compressive elements are removed using hand tools and an upgoing curette. The dura is visualized here with removal of these compressive elements. We place the ultrasound probe on top of the dura and we can visualize the heavily calcified ventral thoracic disc herniation with severe cord compression. The cord is not pulsatile. We move on to use the ultrasonic aspirator to remove the medial aspect of the pedicle and to get a more ventrolateral exposure. This is only a partial transpedicular approach. The majority of the pedicle is still present. This does not destabilize the spine. After removing the medial pedicle, we're able to work in a small corridor and gently place a retractor onto the thoracic disc herniation, which is visualized here. We turn the ultrasonic aspirator towards the midline and use it to undercut the thoracic disc herniation, detaching it from its base. We can then use dental instruments and downgoing curettes to collapse the roof of the ventral compressive disc herniation. The soft component of the disc herniation is being removed here. After removing these pieces, we're then able to remove more pieces using downgoing curettes and dental tools. These are more fibrous elements being removed at this point. We place the ultrasound probe back on the dura and we see that there is still residual compression. This is a very valuable tool to make sure you have fully decompressed the thoracic spinal cord. We move on to remove the ventral, highly calcified portions of the disc herniation using the ultrasonic aspirator. We can work somewhat blindly ventral to the thecal sac using that device, as well as collapsing the roof down along these more calcified fragments. There is minimal cord manipulation. We used neuromonitoring during the procedure and there were no changes noted during this operation. We again push down the remaining compressive elements and evacuate them using a pituitary. The ultrasound on the axial view shows resolution of the compressive pathology. On the sagittal view, you can see that the spinal cord is well decompressed. There is normal CSF pulsation. The cord itself is pulsating back and forth normally. We know we are done. There is no ultrasonic evidence of any cord signal. The patient woke up neurologically intact.
So that's kind of that's what we do now. So we don't do a transdural unless it's really stuck and you can't get it out through that way for whatever reason. And so I want to make one point. We did this yesterday too, because we put that little micro Penfield 4 on the lateral dura and kind of gently moved it over by 2 or 3 millimeters or so in these cases. And so I've always wondered what the cord looked like when you did that. And we don't have any neuromonitoring changes. These people do well. And so I always thought it was just CSF displacement. This is kind of what it looks like. So when you displace it over like that, that's about as far as we go. And the cord tolerates that. And that gives you a lot of room to do what you need to do in that one particular corridor there. And obviously you go further than that, there's gonna be problems, but you obviously don't try to do that. But that's one of these, when you see that video, you see that retractor, and anytime you hear the word retractor and next to a spinal cord, it doesn't sound good. But honestly, it's a safe thing. So that was our series of 43 people, and then we had done 3 transdural approaches, and then we had written that up too. But then we just time went on, and then these people kept on showing up, and then so now we have 108 people, and then 137 discs. So this is our pre-publication data for this transpedicular approach. And so, like I said, 108 people, the mean age is around 58. A good number of them, 20% had a BMI over 40. Good chunk had diabetes, and then symptom duration was typically pretty long. So 12 months or so of symptoms before either diagnosis or surgery. The discs were, for the most part, paramedian. They were, for the most part, partially calcified or completely calcified. They were nearly 70% of them were considered giant thoracic discs, so occupying more than 40% of the canal, and then 65% had pre-op cord signal change. Most of these folks had sensory deficit, hyperreflexia, myelopathic signs or symptoms, which justified doing surgery, obviously. And then the urinary and bowel incontinence rate was pretty high too. I mean, that's obviously from the cord compression. The operative time was 174 minutes, so doesn't take that long to do it. I think you did with ultrasound. I think you just kind of pick away at these things sometimes, which adds to operative time, and you kind of make it perfect, or you have the opportunity to make it perfect. Most people are gonna stick around longer and try to make it perfect. Blood loss was 200 cc's. It's higher if we ever had to fuse somebody. We rarely had to fuse people. We did fuse them if we took off more of the facet and destabilized them, or if there was a recurrent disc herniation, for instance, and then we just had to stabilize that segment. So blood loss with fusion was obviously higher. Without fusion, it was about 170 cc's. 3 people had to get a transfusion. The monitoring stuff is pretty interesting because there were 10 patients that improved, 3 declined, 5 declined and then recovered during surgery, and then 83% had no change at all. So no change at all is obviously really reassuring. Improvement's really cool because if they're improving on neuromonitoring, you hope that they're going to just definitely improve postoperatively. The decline, then recovery, and the decline are not good, and then you hate to hear that stuff, but that's just part of dealing with a really challenging surgical problem. The good news is that when we follow these people out long term, only 1 patient actually had some decline in Frankel grade. And so for those that are not familiar with the Frankel grading, this is it here, but E is normal, D is preserved motor function, C is preserved motor function, but you have to use a walker or something, some sort of assistive device. And then B is preserved sensational, and A is complete. But if you look at these folks in the series, basically there was the people changed Frankel grading as they recovered from surgery. So if you started off weak, people improved, and this is better shown in this distribution graph, which shows that preoperatively, if you the pink is the E, that's the good, right? So people shifted into E, which is normal, and there was only 1 patient who had a decline of 1 grade at the final follow-up. So the other 107 patients stayed the same or got better with improvement in their Frankel grades. Some people improved by 2 or even 3 Frankel grades. So 5 patients improved by 2 and 3 improved by 3 Frankel grades. So it had a pretty drastic improvement over time. And that was at the 3 to 6 month follow-up. At the last follow-up visit, 9 actually improved 3 by 2 Frankel grades, 3 improved by 3 Frankel grades, and 1 patient actually went all the way to 4. And the same improvements we're seeing with the giants too. So if you just isolate the giant, the same improvements and trends we're seeing with the giant thoracic disc herniations.
Stephen, how often are you having to go bipedicular in these cases, or are you able to get the majority of these discs out from a unilateral approach?
So great question. I always start for the most part, unipedicular, and then I try to take it out from just that one side. Um, with the midline ones, especially if they're really heavily calcified, and especially if you look at the preoperative CT scan and the base is really wide, and by that I mean medial lateral, but also superior inferior. If that base is really wide, it usually is connected to the contralateral pedicle and the vertebral body, and it just will not collapse down, especially the calcified ones. They just will not collapse down unless you go to the opposite pedicle and do the same thing on that side, carve out a trough in the vertebral body in the contralateral pedicle and detach it. And then once you detach it there, it's detached everywhere and it's just a floating thing. You push it down and it'll go away. So I don't know like what percentage of the time I'm just doing unilateral, but I always start unilateral and just try to do it that way. And then if it's just fussy and won't come out, then I'll just go the opposite side and do the same thing. These are the complications. So wound infection in 2, seroma in 2, reherniation in 5, epidural hematoma in 1, and then somehow, like we talked about, no CSF leaks through the wound or anything like that post-op, even with the transdural ones. The length of stay was on average 4.5 days. That has changed a lot. So now we have, at least in this series, 20% of the folks, went home same day. So that's on, under, just an overnight stay or same day discharge, which is really cool to see. So, doing these procedures, which used to be chest tube in an ICU to an outpatient procedure, has been cool to watch. So if you look at other series, complication rates, have been reported of 30, upwards of 82% in 357 patients. The average for the minimally invasive approaches were obviously less than that. So that's 28% in 466 patients. And that was a literature review and case series reviewed by a busy group. And then they had a minor complication in 5 instances, which is 8%, and major complications in 4, which is 6.7%. And so it's a 15% total complication rate for like a MIS lateral type of approach. And so our series is like that, or maybe a little bit less. I mean, it's because we had 8.3% of minor complications and major complication in 1 with the epidural hematoma. So I think this shows that this kind of approach is safe, and it's utilitarian. It's pretty robust for thoracic discs and both calcified and non-calcified nature. If you just review the literature, I mean, it's the posterior approach just in general is less morbid compared to the anterior. This is an excellent safety profile. The central herniated discs are just can be nightmares, but if you're more comfortable doing it through the chest or through a retropleural approach, then that's just surgeon preference and training. I think that's obviously the way it's been done and it works. So times are changing. I think this is just a great option if you're more comfortable going posteriorly, and if you want to use ultrasound and a sonopet to tackle it this way. I think it works really well, and it's safe, and patients do really well. So in summary, it's minimally invasive, and aside from endoscopic, I think this is the least invasive approach. It's familiar, so the kind of the downfall, or not the downfall, but a downside to the endoscopic stuff, it's not really familiar to a lot of surgeons unless you trained on it, or you're gonna go and jump over to do a lot of endoscopic. It's different instruments and different tools and stuff. So this approach is familiar. It's familiar tools. You do need a full laminectomy. I think tubular or hemilaminotomy, I've tried that, and that you start getting some neuromonitoring changes, at least in my experience. I think you need room. You need basically the full laminectomy for the cord to be able to drift backwards. When you put that curette in there, you need a little space for the cord to get out of the way. And if you don't have the full lammy, then I think that's, at least in my mind, that's why I thought there were some neuromonitoring folks just chiming up in the corner there. No fusions necessary. It's safe. We talked about that. It's a low complication profile for a very high risk problem. and it's universal. So you can get the giant calcified midline thoracic disc this way, and even at every level. So the upper thoracic level, which are inaccessible through a thoracotomy, you'd have to do a sternotomy if you're going to go anterior. And then we mentioned the transdural option if necessary. So a year or two ago, this paper popped up in my my little like Google Scholar alert, and I was like, oh boy, I was like, this doesn't sound good for me. And and so I read this, and so this is just the title of the paper is Lower Neurologic Risk with Anterior Operations Compared to Posterior Operations for a thoracic disc, and that's a lot of patients. So I reviewed this, looked into this paper, and then here's the deal though, the p-values are not significant. So there are people that are, I think a little bit um, worried about going posterior only, but I think with more people publishing on this and writing it up, I think we're showing that it's actually very safe. And I don't think you can say that anterior only is safer. Of course, there are problems. And so this is where we get into the complications. And, this is one of those days without fall thing. They clearly just erased whatever it was, 20, and then wrote 0. And so that's a bad day for the nurses and stuff. No one wants to see that. But this is one of the worst thoracic discs I've ever seen. And it's not because of the size. Yes, it's big, but this is when I realized that the shape of the disc makes a lot of is very important. And if they're sharp like this and pointy, it's not good. If the cord like teeter totters on either side of this thing, it's almost like it wants to, it can be a nightmare. And so I think it's a separate risk stratification in my mind. If the disc is pointy and razor like this, it just can be nasty. Um, this guy, even with decompressing in the back alone, we lost motors, and then he was pretty weak after surgery, but he recovered and was walking and is if Frankel E. So he made a remarkable recovery. It's just a high risk surgery. I think in the past it's probably one of those cases they would just do the laminectomy on, and then the patient would wake up paralyzed. But I think the key here is if you have monitoring changes, there's still some severe compression there. You got to move forward and take the whole thing out and get the cord decompressed.
Stephen, I've seen this happen before in posterior transpedicular discectomies where you do your laminectomy and you have pretty significant drop in MEPs. What are your thoughts in a case like this to maybe going transpedicular first, start to kind of core out the disc and then do your lami afterwards? I know it's kind of, in contraindication to what you just said before, but I think kind of the theory here is that when you do a laminectomy first, you're obviously taking the ligamentum flavum, right? And that's almost tethering the dura dorsally. Once you do your laminectomy, the dura is no longer tethered dorsally. So now it kind of drapes over that, ventral calcified disc. And you see the same thing if you're doing like a big deformity case with a huge ventral kyphus, you do your lami first. A lot of those patients, that cord will drift forward. So what are your thoughts about maybe doing, transpedic discectomy first and then lami?
Yeah, that's a good thought. I'm not sure how well I would see this thing, is one concern, but I think that's a good thought. Like, yeah, just start drilling the thing away and removing it. I think a lot of it's reperfusion too. You decompress this thing and it's just immediate reperfusion injury. And so I don't know if there's a very good option. And like I said, I think I've only seen that happen one time. And so this may be one of these cases, if I could do this again, I would maybe consider even going like retropleural on this thing, or just going directly transdural or something like you said, like having a different, I don't know. I don't know if there's like a perfect option here. I think this is just a nightmare of a type of surgery.
Right. It's hard to predict.
Yeah.
Someone in the audience had asked a few minutes ago, it's a bit off topic, but what's the mechanism of reherniation in a case like this? Like, have you ever taken out a calcified thoracic disc and actually seen it reherniate? I personally have not. I'm curious what your experience is though.
I have, and I remember on one of the transdurals we actually had a reherniation, and that was kind of a mess because there's just disc like inside the dura and stuff. So I have seen that, and I suspect it's similar to where reherniations happen elsewhere. It's there are fragments that are still within the disc space. I don't go into the disc space and take stuff out. I take just the chunk out that's on the cord. So for whatever reason, I think there's probably stuff in the disc space. And I remember that in a few of these cases, just realizing that there's just free stuff in the disk space that just wants to keep on coming out. So it's probably motion and just residual stuff in the disk space. We ultrasound, so we know it's clear at the end. It's not one of these things where you say it's reherniation. It's actually you didn't take out the whole thing. So I think it's probably motion, which is why we fuse them. All right, so here, oh, here's that guy. So this is that guy where this is his post-operative MRI scan, and he ended up, like I said, doing great. It's just like high risk surgery. So this is that complication that trains Doral was talking about. So this patient, it was just super stuck ventrally, and it would have been one where if we tried to take it out, we would have gotten a leak anyway. This is the preoperative CT scan. Again, it shows that like really calcific discitis that starts in the disc space and spreads. And then this patient did well. Okay, so she went home in a normal time frame. I don't have that written down, but did the regular. And then 3 years after surgery, she has this MRI scan, and she has focal tethering. There's that scalpel sign, right? There's she has like an arachnoidal web. She came to my office, and she feels like her legs are subjectively weak. They're giving out. She's developing myelopathic symptoms again. She did great from her thoracic disc surgery, and 3 years later, this happens. And so for those who are not seeing this, this is that scalpel sign where there there's a web, so the spinal cord is not ventrally herniated. There's just arachnoid that's tethering here, and it's from scar, and it's from going transdural, and it's from all the inflammatory disc material being pulled out and that kind of thing. And I don't know a good way to prevent that, but this is one of the problems with doing any intradural surgery. But you've taken a thoracic disc surgery, which is typically not intradural, and you do have this risk that you need to talk to folks about, as a potential downfall. So anyway, we went in, and then that's her scalpel sign, and the cord is swollen, and it wasn't like that post-op. So this is all new, and then this is it afterwards. So we went in, re-explored, opened up the dura, cut the arachnoidal bands, kind of freed up normal spinal fluid flow above and below, and so her scan went from this to that 3 months after surgery. And so she went back to her neurologic baseline full strength, and then that subjective weakness in her legs that she was talking about went back to normal. That went away. So again, that's a problem with transdural surgery in general. Okay, so maybe for the group, what would folks do for this one? So this is a 45-year-old guy with numbness and tingling in the legs and some weakness.
I'll be honest, it doesn't look that impressive, the disc, right? But
Yeah.
there looks like there's some cord signal change there. I've seen a ton of these, not necessarily with the cord signal change, but patients who present and they've got some, soft symptoms of myelopathy, and they've got maybe two or three of these tiny little punctate disc herniations where the cord is ever so slightly effaced. And I never know what to do with them. I usually don't operate on them, obviously, unless they've got cord signal change. This is a very interesting case, though. I'm not sure what I would do here, to be honest with you.
Yeah, so
You did though.
this guy, you get the phone call, and I have the same thoughts, right? It doesn't look that bad. There's a lot of core signal change, and you get a little bit more of a history. And this guy had an acute onset of weakness. This is not an acute disc, and he really was motor really profoundly affected, very weak in his legs, lots of sensory changes, and he had a lot of pain. And so this guy actually, we said that we don't think it's the disc, and so we worked him up, and he actually had transverse myelitis. So so it's one of these rare cases where there's
Right,
transverse myelitis at the same segment where there's a small thoracic disc herniation.
right. Yeah,
So
hey, I've seen weird stuff like this too. That's probably a great board question, right?
yeah, yeah,
Don't be tempted to go after that little thing.
yeah. But thanks to all of our residents, Holly, my nurse practitioner, Brian Saway, who's one of our residents here, has really worked so hard and done so much research in this field on ultrasound, thoracic disc, everything. He's an all-star. So a special shout out to Brian, who's rocking it. Um, and that's all I have. So any questions or comments, I can answer.
Yeah, that was absolutely incredible, Stephen. I really enjoyed that a lot. Looks like the audience members have as well. So I think I asked you all of my questions that I had. Um, Great meeting, great talk. Lot of nice comments here. Someone had asked about how you would manage a CSF pleural fistula. I think one of the first cases you showed,
Mhm.
there was one of those complications. So how would you manage that? Typically, you know, we would place a lumbar drain, but would there ever be a situation where you go back in and maybe directly patch it up?
Yeah, so I thankfully I have not had to do that and patch it, but lumbar drain for sure helps. The textbook thing that you always think about and have in the back of your mind is a omental flap. And I have not had to do that, thankfully, but that's apparently what you do. Is you get your general surgery friends around and you bring up omentum and you slap that down on top of the the leak site and the lateral aspect of the dura and the transthoracic thing, and then that gets it to scar down. So I imagine it'd be like some sort of CSF diversion with some vascularized flap, omentum or something like that to get it to sock down. And then obviously there's shunting. I've had not for a thoracic disc, but you got to think about obviously just ventricular peritoneal lumbar peritoneal shunting as a management strategy as a bailout too.
Well, I think we're just about out of time, Stephen. That was fantastic. I have to say that was a very refreshing talk that you gave. You know, everything these days is about endoscopy or lateral retropleural techniques, and I feel like no one talks about the posterior transpedicular technique. You know, this is a fantastic modification that you've come up with where we really don't need to, you know, lop out everyone's pedicles and facet joints and do you know, a 4 or 5 level fusion. And I think this is a great hybrid, very practical approach to taking care of very challenging pathology. So I appreciate you really sharing that with us. I think this is going to get a lot of hits on YouTube. I'm sure I'm going to end up watching this again next time I have a thoracic disc as well. So appreciate you being here tonight. Thank you.
It's very nice of you to say. Thanks for having me, and thanks for everybody for coming.
All right, guys, have a great night. We'll see you next week.